probably our value liver injury other medications prefer ስለዚህ ፌንቶይና ቫልፖሬት አንድ ላይ ለምትሰጣቸው የሚያደርገው ሲነርጂስቲክ ፖቴንሻል ያደርገዋል። ስለዚህ ብዙ ጊዜ ፕራክቲስ ይደረጋል።
Thank you again. This is about approach to stroke. This is the outline of the presentation, and these are the objective. At the end of the seminar, we lower or we define stroke, we describe about the risk factor, and we know the classification, and we understand and we know the outcome of stroke, and these are the objective of this seminar. So starting from the introduction, stroke is defined as it is a sudden when there is a sudden neurological deficit that is vascular cause, and it originates from the vascular region, and that lasts more than 24 hours. It's known as a stroke. That means there is an occlusion on the vascular system. That occlusion results in neurological deficit that is more than 24 hours, or if there is any infraction, regardless of this duration, is known as a stroke. By definition, the stroke is the sign must be greater than 24 hours. But if there is an infraction without this time, we can say stroke. There is one thing here that is important, that is ischemic stroke. That means when the neurological symptoms lasts for 24 hours and they resolve within 24 hours, we say that transit ischemic stroke. That means the duration is within 24 hours and there is no infraction within that 24 hours. If there is infraction, it is known as a stroke, and it's mostly it refers to the non-traumatic hemorrhage and the ischemic hemorrhage that involves the cerebral infraction and the non-traumatic, because there is also traumatic hemorrhage like epidural and subdural. It's not our topic, that also due to traumatic and surgical causes, but we are focusing on the non-traumatic cerebral hemorrhage. So when it comes to the epidemiology, it is the second leading cause of death worldwide, and around 77% of this stroke is primary stroke. There is primary stroke, and there is also transformation stroke. That means whether hemorrhage can transform to the other hemorrhage, but mainly around 77% in the worldwide it's primary stroke, and it is the most common and devastating neurological emergency. And in our country, when there is a research done in the hospital between this period, and the report says that around 57% is hemorrhagic stroke, and from this hemorrhagic stroke, hypertension is the most common cause of stroke, not for hemorrhagic, but in general hypertension is the most common cause, and the second one is the cardiovascular disease is the second, and from the cardiovascular disease, valvular heart disease is the common. From this valvular heart disease, atrial fibrillation is the most common cause of a stroke. Is done in Dr. Ambassa hospital, and there is also other research done in Jimma hospital in 2019, and they estimate that the ischemic stroke is around 52%, and the hemorrhagic stroke is around 48%, and there is also the study done in Mirgalam hospital at 2021, and they say that around 62% or 62.7% is ischemic, and the remaining one is hemorrhagic stroke. So it tells us it is unique for hemorrhagic is the most common, but in other studies the ischemic is the most common, but relatively in the worldwide the ischemic versus Ischemic versus hemorrhagic, it's 4:1 ratio. But in our country, the study shows that the ischemic and the hemorrhagic are not that much of comparable. This is a classification of stroke. It is worldwide. Stroke.
ያው ብዙ ጊዜ የሚያገለግሉ ችግር ሲፈጠር ሆስፒታል ብዙ ጊዜ ሚስኮንሰፕሽን ብዙዎቹ ወደ ሜዲካል ምናልባት አሁን ኢፒዲሞሎጂ እየተቀየረ የሚመጣው ሜዲካል ሲኪንግ ቢሄቪየርን እየጨመረ ሲመጣ ከሲቪላይዜሽን ከካርዲዮቫስኩላር የሚገናኝ ነገር ከዛ መጋመና እየተባለ ስለዚህ ፔሸንቶች ግን አሁን ፑር አውትካም ያለው ከስቴሚክ ስትሮክ ሄሞራጂክ ማስ ኢፌክት ስላለ ፔሸንቶች ዊዛውት ሜዲኬሽን ወይም ስኮማ ምናምን ፕሬዘንት ነው። ስለዚህ ሆስፒታል ላይ ስትሰራ ዳታው we find more hemorrhagic patients because those ischemic patients will not have especially በራሱ ሪዞልቭ ያደርጋል ወይም ደግሞ የሆነ ሳተር ተያይና ሲስተም ናቸው። ስለዚህ ኢፒዲሞሎጂ ጋር ለዛ ነው ፕሬዘንቴሽን ሞር የሚለው እንጂ ስናት ኢፒዲሞሎጂ ቼንጅ አድርጓል። ischemic is a but based on the presentation hemorrhagic looks common especially based on the research.
Yes. This is worldwide. Strokes can be classified as ischemic and hemorrhagic. The hemorrhagic is around 50% and the ischemic is around 85%. From this, the ischemic one is it can be embolic and it can be thrombotic. The embolic is around 75% and the thrombotic is 25%, and the hemorrhage can be intraparenchymal or subarachnoid hemorrhage, or it can be pure intraventricular hemorrhage. So when we start from the ischemic stroke, when this is a type of stroke that's due to the vascular occlusion in the cerebral artery, whether in the cerebral, whether on the other sides or on the particular focus of the brain, there may be an infraction of the artery, or less likely from the vein, there may be an occlusion that results neurological deficit. This is the definition of the stroke. As you know, there is cerebral perfusion pressure, so there is cerebral blood flow. The normal cerebral blood flow is around 50 to 60 ml per 100 gram per minute. If it is less than this amount, the infraction may be occurred depending on the duration or the time. That means if it is between 20 and 40 ml per 100 gram of tissue per minute, it may take a hour to be infracted. Or if it is 0 ml per 100 gram, there may be 4 to 10 minutes may be enough to cause an infraction. So it is when there is a arterial occlusion, the infraction will be occurred. These are most of the common causes, and there are uncommon causes. The common causes for thrombosis, the lacunar stroke, that means the small vessel and large vessel thrombosis, and hypotension also can cause thrombosis, thrombotic stroke. And the embolic one can be due to artery cardioembolic and paradoxical. When you say artery to artery, it can be from the carotid bifurcation, it can be from arterial dissection. When you say cardioembolic, it can be atrial fibrillation is the most common. And when you say paradoxical, it can be from the atrial septal defect, or it can be from the patent foramen ovale. These are the most common. The left side ones, there are also other uncommon causes that results the ischemic stroke. The risk factors, there are modifiable and non-modifiable risk factors for the ischemic stroke. The first one is the non-modifiable risk factor, age. It's most common above 40 years. Yeah, and the gender is more common on male, 1:5:1 ratio. And the race, family history, and genetics also non-modifiable risk factors. The modifiables are mostly associated with lifestyle modifications and chronic diseases like hypertension, DM, and dyslipidemia. These are the modifiable ones. We can modify this by changing our lifestyle, by treating these diseases. So these are the modifiable and non-modifiable risk factors. And when we come to the pathophysiology of the ischemic stroke, if there is a blockage on the area, on the particular area of the brain, there is a occurrence of ischemia. If there is an ischemia, there is energy failure. If there is energy failure, and depolarization will be occurred on the cell, on the cellular level. That cellular level, if depolarization occurred at the particular level of the cell, there is a release of glutamate. The glutamate release of, if the glutamate is activated, there is a release of calcium influx. There is a calcium influx to the cells. That calcium results the swelling of the cell, or it can result in enzyme activation, or it can result in mitochondrial damage, or it can also result free radical generations. So the infraction can be, this infraction can be by two pathways, whether necrotic pathway or apoptotic pathway. When you say necrotic pathway, due to the infraction. When you say apoptotic pathway, it is the programmed cell death due to the influx of these calcium ions, and the site of infraction also varies. That means depending on the site, depending on the collateral circulation, and depending on the duration, and depending on the reperfusion capacity, the infraction will be vary. When it comes to the clinical presentation, the patient who is ischemic stroke, they may be present with weakness. It can be monoparasis, hemiparasis, and quadriparasis may be occur, and they may have loss of coordination or balance, sensory loss also, and there may be also a speech problem can be also. These are most of the common clinical presentation when a patient is present with ischemic stroke. When it comes to the hemorrhagic stroke can be, this is about the non-traumatic hemorrhage that can be subarachnoid hemorrhage or intracerebral hemorrhage. When you say intracerebral hemorrhage, there is a bleeding on the parenchyma or interventricular, but the subarachnoid hemorrhage, there is a bleeding or there is a rupture of blood vessel at the level of the subarachnoid space, and there is blood on the subarachnoid space. Trauma is the most common for the subarachnoid space. So these are the hemorrhagic stroke types. The etiology are the most common: the head injury, hypertension, coagulopathy, and metastatic tumor. And drugs like amphetamine, cocaine can also cause this hemorrhagic stroke. When we see the pathophysiology, it results from the spontaneous rupture of the arterial level, or mostly from the deep arteries, that means from the penetrating or the end arteries can cause this pathogenesis. When these deep arteries are infracted, the result is the formation of bleeding that occludes the blood flow to the other area, and transformation may be there. And the mechanism of brain injury can be, that means the brain is injured during hemorrhagic stroke by mass effect, maybe by mass effect, maybe by increasing the ICP, it may be by direct mechanical injury to the brain parenchyma. It can be cytotoxic effect. This is also one of the manifestations that results the neurological symptoms. Neurological symptoms of the brain can be occur due to this mechanism. So brain injury is due to these scenarios. And the clinical presentation, when we see the clinical presentation, the most occur during the routine activity. They are occurred in the routine activity, and mostly the hemorrhagic stroke present with headache, vomiting, decreased level of consciousness. In ischemic stroke, mostly there is no decreased level of consciousness, but in hemorrhagic stroke, there may be a decreased level of consciousness due to the previous mechanisms. These are the clinical characteristics that differentiate between stroke. You know that there are ischemic and ischemic and hemorrhagic stroke. From hemorrhagic, there is intracerebral hemorrhage. When we see the course of the intracerebral hemorrhage, it is gradual progress. That results from minute to hours. It's a gradual progress. If it is gradual progress, we may probably say it is intracerebral hemorrhage. But if it is abrupt, and if there is a severe headache, we may say hemorrhage. Which type of hemorrhage? Subarachnoid hemorrhage. And from the ischemic, it can be thrombotic and embolic. If it is maximal at onset, That means the weakness, neurological signs and symptoms are at maximal onset or during the onset. If it is maximal, we say the embolic types of stroke. If it's stuttering type, that means there is stuttering, there is the neurological signs may be increased, decreased, and relieved, and they may be regressed. So if it's this type of neurological signs, we say that the thrombotic, and the risk factors also helps us for determining which types of stroke. These are the presumptive diagnosis, only for presumptive diagnosis, and only for identifying the causes that are which diagnosis or which stroke is probably may have this patient. This for that purpose. And there are also other stroke types. There are stroke syndromes. These are stroke syndromes. When you say stroke syndromes, these are based on the territorial or arterial supplies. You know that the brain have arterial supplies. It has supplied by the anterior cerebral artery, the middle cerebral artery, and the posterior cerebral artery can supply the brain. The anterior cerebral artery supplies the part of the brain which is localized at the level of the which is the part or the brain that localizes the lower legs and the urinary bladder. That means the brain which is localized, or the location of the brain that controls the leg and the urinary, around the urinary point is supplied by the anterior cerebral artery, and the place where the upper extremity, the trunk, and the face can be supplied by the middle cerebral artery, and the posterior cerebral artery supplies the posterior side, that's the thalamus cerebellum, and basal ganglia can be supplied. So this artery tells us the to localize which part of the brain is affected and which arterial supplies affect. That's known as stroke syndromes. And also there are also small vessel strokes, that's known as lacunar strokes. Lacunar strokes are due to the end arteries, that's end penetrating arteries, and the accounts around 20% from all strokes. So it's also the stroke syndromes. So the other is the patient approach. So if this is stroke, how we approach the patient who presented with like this sign and symptoms. The first, we have 4 goals. In patient approach, we have 4 goals in stroke patient. The first one is identifying and stabilizing the patient. We identify and we stabilize the patient. Then the second one, we determine the presumptive diagnosis based on history and physical examination. Then the third one is the confirmation of the diagnosis. The confirmation can be done by the CT, neuro, or by CT or MRI. We can confirm. After that, we treat the patient. The fourth one is we treat the patients based on the type of stroke. That's different. Ischemic and hemorrhagic stroke is different management protocols. So for when we approach the patient, these 4 goals must be addressed and identified, and we do accordingly. So on history, we can ask the can ask the time of onset, the mode, duration. These all things must be addressed on history. That means on history we can get the probability of our presumptive diagnosis. That means whether ischemic or hemorrhagic, we can get the diagnosis. So we can ask the risk factors. For example, a patient who have hypertension, dyslipidemia, or any metabolic abnormalities, we have this risk factor, and we do presumptive diagnosis are the history. And on physical examination, we start from the general appearance. In the general appearance, there may be unconscious, acute sick looking, or there may be chronically sick looking, maybe a vital sign may be deranged. On HNT, we may see on the eye, we may see signs of retinal damage. It can be on the lymphoglandular system, we may see the enlargement. So every systems will be addressed. This is not one part. So every system must be addressed. For example, when on the CNS, we see the level of consciousness, we see the language, speech, we see the motor, reflex examination, sensory exam, and meningeal sign also must be addressed. This is about the physical examination. On the diagnosis, there is no 100% effective. On American Stroke Association, they have no any errors, or currently there is no 100% effective effective diagnostic modalities. Rather than they select some diagnostic for all patients and some diagnostic modalities for some patients. Rather than there is no effective 100% effective diagnostic modalities. So our diagnosis is based on clinical plus this neuro imaging can assist the diagnosis. So CT and MRI is the most investigation modalities for patients who present with signs and symptoms of stroke. CT is the standard or the gold standard modality, even if it cannot show the ischemia before 3 hours. Is the gold standard. MRI is better if it is before 3 hours, and MRI is better if it is posterior cerebral artery or penetrating artery is injured. MRI may be more sensitive than this CT, but after 3 hours, CT is sensitive to detect the infraction. That's due to infraction is occurred. To be infracted in a brain or to show, the 6 hour may be required. That means 6 to 24 hour may be required to detect the CT, but it is the gold standard diagnostic modality. So for investigation for all patients, this investigation modality can be ordered based on our clinical scenario. That's non-contrast CT, brain MR, electrolyte, organ function, ECG, CBC, and bleed, and PT, INR, and APTD can be sent for all patients. And on selected patients, we can order chest X-ray, EEG, and pregnancy test, and cardiac markers, and blood alcohol level can be ordered for selected patients. This is according to American Stroke Association. And when we come to the imaging, as we say, the CT is CT and MRI is the best modalities. On CT, we can see is that hemorrhagic or ischemic. The first one is it shows there is a hyper dense area. That's from the other area. There is a different area that's hyper dense, and there is a cellular swelling that tells us there is a hemorrhage at that particular point. And the second is there is a hypodense, that means a black the arrow, a black area that is different from the surrounding tissues, that tells us ischemic stroke. So we can identify by CT immediately, by non-contrast CT, whether it is ischemic or hemorrhagic. By hemorrhagic is a hyperdense, the ischemic one is a hypodense. The other one is the management. The primary goal to manage the stroke is to reverse the ischemia. That means to reverse the ischemic penumbra. That means when you say the ischemic penumbra, it is a point that is the reversible part of the cell death. There is cell death, but it can be reversed. That's known as the penumbra. The blood, cerebral blood flow is between 20 and 40 ml per 100 gram. So the initial measure applied to all stroke patients, these are for all, whether hemorrhagic or whether ischemic. We apply this. We do ABC of life as a particular, and we determine the exact time of onset. Then we examine the patient and assess severity. Then we do non-contrast CT. These are for all hemorrhagic and ischemic stroke. After that, we go for hemorrhagic different management, and for ischemic different management. So in acute ischemic stroke, there are medical supportive cares or general supportive cares for the ischemic stroke patients. The first one is airway and ventilatory support and supplemental oxygen. The patient may need ventilation, it may need intubation, it may need intranasal or face mask oxygen, it may need also mechanical ventilations. If it is there is an indication for intubating, that means if it is GCS is less than 8, this is an indication for, due to the prevalent aspiration and to give the time for the respiratory muscles. It's an indication if it is GCS is less than 8. So it's an indication because of the risk of aspiration. And the second one is the temperature. It is whether the hypothermia, if severe hypothermia, mostly hypothermia is neuroprotective. That means in stroke patients within 24 hours, 32 to 36 we keep the temperature between 30 to 36 degrees centigrade within 24 hours. If it is hyperthermia, it worsens the ischemic stroke due to it demands the metabolic, it creates the free radicals, and it also may be a result from infection. So we must treat the hyperthermia. Hyperthermia must be treated and addressed accordingly. That means whether infectious, whether other parameters, we address and treat the temperatures. The third one is the cardiac monitoring and treatment. The patient with a stroke may have atrial fibrillation, may have dysarthemia, other dysarthemia may have. So we monitor the patients with monitors by cardiac placing, by placing of the electrodes. After that, we treat the hypotension and hypotension. This all, whether hypertension or hypertension can worse the outcomes. That means if there is high elevated blood pressure, there is edema formation. If it is low, there is ischemia. So we must keep the cerebral perfusion pressure between 60 to 120 millimeter of mercury. If it is below 60, it can cause ischemia. If it is above the 120, it can cause the cerebral edema. So we must treat hypertension as well as hypotension. But there is an indication to treat the hypertension status. That means there is, according to this American Society of Stroke Society, there is an indication to treat the hypertension level. The first one is if you want to treat recombinant tissue plasminogen activator, and if the blood pressure is greater than 185 to 110, we must treat before administering this. The other one is if the patient have any medical complications like acute coronary syndrome, like heart failure, like other pulmonary edema, eclampsia, preeclampsia, we must treat the patients. And if the blood pressure is greater than 220 by 120 millimeter of mercury, we must also address and treat. The other one is if hypotension is there, we must also address and we must also treat. Even we may give 500 ml of NS bolus for if the patient is hypotensive state, and we may put the patient on a vasopressor because this hypotension can also its own effect. The other one is keeping the hypoglycemia and hyperglycemia levels. The hypoglycemia may mimic the stroke, so we address and we detect the hypoglycemia level and we treat accordingly. The hyperglycemia is also as a hyperthermia. The hyperglycemia is poor outcome. If there is a hyperglycemia, it worsens the ischemia due to the formation of lactic acid, due to the formation of due to the creating of the blood-brain barrier is increased. If that finally results cerebral edema, so hyperglycemia must be addressed and treated. There is no consensus about the hyperglycemia, which the goal of the hyperglycemia, but some says more than 180. If it is more than 180, we must treat. Some says if it is more than 140, we must treat. But currently the goal is we keep the hyperglycemic status, the random blood glucose status between 140 and 180 milligram per deciliter. This is the goal. That means 140 to 180 milligram per deciliter. These are the general supportive curve for ischemic stroke. And in ischemic stroke, there are 4 components of care. The first one is acute therapy and optimization of the neurological status. That means the revascularization state, whether by RTPA or by endovascular thrombolysis. The second one is prevention of neurological deterioration or medical complications. That means if there is a neurological deterioration or complication, there may be other causes maybe, and we must address that cause and we must treat that causes, and we treat the medical complications. There are some common medical complications. Every system is affected by a stroke, but commonly the DVT, the aspiration pneumonia, urinary tract infection, and also if the patients on heparin-induced thrombocytopenia may be a medical complication. So we address these complications and we treat these complications. And the third one is etiological workup for secondary preventions. So when we say secondary prevention, after the occurrence of ischemic stroke, we address the etiologies and we prevent that etiologies by antiplatelet or anticoagulant medications. The last one is recovery and rehabilitation. So acute therapy on optimization, as I said, it is about the RTP. RTP is it reopens the occluded vein. That means in ischemic stroke there is occluded vein, so it reopens the occluded vein and it stabilizes the arterial supply system. So the mechanism is by fibrolysis. The mechanism of the RTP, the fibrolysis mechanisms. So there is a time to administer this RTP. Some says that if the onset is less than 3 hours, we can administer. Some says that if it is below 4.5 hours, we can administer. But between 3 to 4.5, we can administer this RTP to reopen and to address the vascular supply. These are the indications and contraindications, and after administration what we have do and the dose, what amount of the RTP is given. So these are the indication, and the second one is the contraindication. So we follow this after administering, we follow these criteria. So before bolus or administering, we see that there are drugs for hypertension. Even there are common drugs, that is the labetalol and